شلون how to flip؟ ها؟
لا ده حاجة تسيير بس.
اوكي
شوف
الفليبنج. اوكي في مايك عندكم؟ خذ المايك ذا عشان بس واحد يقرأ السؤال. السلام عليكم. يلا نبي واحد بس يقرأ لنا السؤال، نبي نكون سريعين لأنه ما في وقت. اوكي اول شيء خلينا نرجع للسؤال. analyze the question. So what you find here? He's old man. Okay. He have what we call this. Okay, if you have stiffness and pain in the shoulder and the hip girdles and stiffness for more than 2 hours, it's inflammatory pain, but we call it polymyalgia rheumatica. Okay, so we have old patients with polymyalgia rheumatica, and we have also jaw claudication, and we have pain in the head, headache, and we have diplopia, eye involvement, and then we go down and we see in the examination that we have tenderness in the temporal area. So what's your thought? And we have also ESR 85. So all this point toward what? What they call it? Giant cell arthritis. So what you will do? What do you think the answer? Yes, excellent. So if you suspect giant cell arthritis, especially with acute vision loss or eye involvement, you have to go with the treatment, initial treatment with prednisolone. The dose is usually 1 mg per kg. If there is eye involvement, they go with IV pulse steroid, and then they go for the high dose. Actually, we have recently the JACTA trial and the guideline. The guideline usually go for steroid. The JACTA trial go for tocilizumab and steroid. And the idea is to reduce the dose of steroid. I will go quick. Okay. ليش نعكس السؤال هنا. So this is a 26-year-old. خلي حد يقرأ ثاني بس ما أدري ليش نعكس. So 26 year وكمل منها. Can you make the mic near? So investigation. So let's analyze the question again. So this is 26 years old woman. So she's young, complaining of dyspnea and exertion. She have constitutional symptoms and myalgia for the past 6 months. She have limb claudication, and she have also discrepancy in the PP. So she have a PP of 120/60 in the right and 95/90 in the left. I don't know why there is no pulse, but I think the pulse is reduced, but I don't know why I don't have it here. Anyway, there is no rush, reduced radial pulse in the left upper extremities, and there is murmur. So all of this is pointing toward what, Victoria? And we have also high ESR. What do you think is the answer? Young female with limb claudication and BB discrepancy and reduced pulse. Yeah. So this is patients have TKA. So as we said before, it's important to analyze the question because usually we have the age help us in differentiating Takayasu from giant cell. So in young, usually the diagnosis will be Takayasu, especially with limb claudication and with PP discrepancy, with the reduced pulse. Okay, so here is some point to consider in large vessel vasculitis. Giant cell is the most common in old patient, more than 50. As we said, steroid is the mainstay of treatment. If we have GCA, it may lead to vision loss, so we have to act and treat fast. We should not delay the treatment. Even if we are not sure of the diagnosis and we are planning to do the biopsy, temporal artery biopsy, we can start steroid and we still can do the biopsy within 2 weeks. Last point is if you listen to PROE, obtain bilateral blood pressure and consider Takayasu in young female with unexplained fever and constitutional symptoms. Okay, خلينا نشوف الميل. Someone read the question. خذ المايك بس دكتور. هذا قدام. أيوه.
65 years old man is evaluated for 1 month history for aggressive phase, reaction 3.6 kg, weight loss and numbness at weakness, the right foot, left testicular pain for 1 week, a painful rash in his legs for 2 weeks. He was diagnosed 2 months ago with hypertension, for which he takes hydrochlorothiazide. A physical examination, temperature 37, blood pressure 165/90, the left testicle is tender, small necrotic ulcer and are noted in the legs. Numbness, the right lateral ankle and calf is noted, as well as weakness of the right foot plantar flexion. These are 100, hemoglobin 10, leukocyte count 13, platelet count 430, creatinine 1.7, and negative urinalysis is not. Renal angiogram show microaneurysm of the renal arteries and deep skin biopsy show mural inflammation with necrosis of medium-sized artery. Which prevalent is the most likely diagnosis?
Okay, so let's go back and analyze the question. So what do you think, Doctor? So what we have here?
Elderly, constitutional symptoms.
Okay, with neurological symptoms and testicular pain. Okay, and skin involvement.
Hypertensive during diagnosis
Mm-hmm.
and started with antihypertensive medication.
So we have skin, neurological, testicular pain, constitutional symptoms, high ESR, anemia, high creatinine. So what do you think? And you see the renal angiogram is very helpful also. So what you will choose? Yeah, excellent. So all of this pointing toward polyarthritis nodosa. So constitutional symptoms, neurological, skin, and testicular, all pointing toward polyarthritis nodosa. It's a systemic vasculitis, and it's described as the biopsy shows, pan-mural inflammation with necrosis of the medial size artery. It's medium to small. Also, the renal angiogram show microaneurysm. So usually it will have microaneurysm and stenosis. Here, some clause that will help you in differentiating the vasculitis. So if you focus on the first line, polyarthritis nodosa, the renal involvement here is not glomerulonephritis, so you will not find active sediment or dysmorphic RBC. You will find the involvement of vasculitis with infarct and microaneurysm, unlike the microscopic polyangiitis and granulomatous polyangiitis. Okay. The second claw in polyarthritis nodosa, it's unlikely to involve the lung, so there will be usually no lung involvement. Previously, polyarthritis nodosa was associated with hepatitis B infection. Nowadays, it's still associated, but less than before, because of the treatment, vaccination, etc. So we have polyarthritis nodosa with HPV, and we have polyarthritis nodosa without HPV. And as you see, it's not associated with ANCA. We can diagnose it, preferably we diagnose it with biopsy, but we can diagnose it with the angiogram. Okay. And here is the guideline, the latest guideline, ACR guideline for the management of active polyarthritis nodosa. So usually we go for, if we have the severe disease, we go for steroid and cyclophosphamide. If we have non-severe disease, we go with the steroid and either methotrexate and Imuran, or Imuran, sorry. Go ahead, Doctor.
55-year-old man is hospitalized for acute respiratory failure requiring intubation and mechanical ventilation. He also has increasing leg swelling with non-healing skin ulcers on the leg for the past 4 weeks and pain with swelling of the bilateral wrist and finger joints for the past 6 weeks. He quit smoking 15 years ago. History otherwise unremarkable. Prior hospitalization, he was taking no medication. On physical examination, temperature 37.2, blood pressure 150 over 95, pulse rate 110, respiratory rate 20, ventilator set rate 14 per minute, oxygen saturation is 92 and FiO2 of 40%. There is blood, the endotracheal tube, lung crackles are heard bilaterally, swelling of the wrists, metacarpopharyngeal joints and proximal interpharyngeal joints is noted. 2 necrotic ulcers on the left leg and 1 necrotic ulcer on the right leg are present. There is 2 plus pitting edema of the legs. Laboratory studies show normalcy.
معلش skip I don't know why it's flipped like this لما حولناها من الكينوت. Anyway, so we have
chest radiograph shows diffuse bilateral
okay.
infiltrates. Biopsy of the skin ulcers shows non-granulomatous necrotizing small vessel vasculitis with immunofluorescent negative for immune complex.
Yeah, so in the lab also we have positive ANCA, بس انها صايره flipped. بس كده ما مبينة. Okay, again, let's analyze the question. So we have a 55 years old man with respiratory involvement, and then we have also skin involvement, joint involvement, and if we go down, we see the BP a little bit high. Okay, okay. Okay, so what do you think, Doctor? Why? طبعا السؤال شوي يعني مظلوم انت في السؤال ان اللاب مش واضحه صراحه بس كده. anyway هو he have renal involvement and he have positive ANCA and respiratory involvement. So yeah, in this case either it's granulomatous polyangiitis or microscopic polyangiitis. What can help you to differentiate between the two? Granulomatous polyangiitis usually having upper respiratory and lower respiratory involvement. So usually they have otitis media, I mean ear or nose or oral inflammation with respiratory inflammation with renal involvement, beside the other things, skin and etc. Okay. So in this case it's microscopic polyangiitis, but I don't know why the lab was flipped. Yeah, next one. Anyone? Yeah.
35-year-old woman present with dyspnea, fever, renal insufficiency, and migratory polyarthralgia. The patient is newly married and would like to have children in the future. She works as school teacher. She reports no tobacco or alcohol use. On physical examination, the patient is noted to have mild synovitis of the wrist and knee bilaterals. The lines are clear on auscultation. The cardiovascular examination is noted for tachycardia with no murmurs. Laboratory study reveals the following: CNK positive, antiproteinase 3 antibodies positive, ESR 80, and positive red cell cast. Chest imaging shows bilateral peripheral opacity with multiple nodule and a small pleural effusion. Renal biopsy shows
Post-immune glomerulonephritis.
The patient is started in oral prednisone at 1 milligram per kg, which is of the following is the best addition to the treatment plan at this time.
Okay, so let's analyze the question. We just talked about it. So what we have here?
Young female patient present with dyspnea and fever with renal insufficiency. There is migratory polyarthralgia.
So we have pulmonary renal involvement with constitutional symptoms and arthralgia, let's say. And what else? In examination, we have so basically arthritis. And we have in the lab CNK positive, antiproteinase 3 positive, ESR is high, and red cell cast. And also in the chest, we have opacities and multiple nodules. So, and the biopsy was showing post-immune glomerulonephritis. So all of this point toward, forget the question. What's the diagnosis? Yeah, it's granulomatous polyangiitis or Wegener. Based on, Dr. Hussein, based on what you said, Wegener? Okay. Yeah, excellent. So, what do you think is the best answer in this question? What you will give beside cortisone? So we have patient with granulomatous polyangiitis. What do you want to give? في ناس قالوا B. Any other thought? Any other thought? Huh? B is wrong. Okay. What is the right? D. Excellent thought, actually. It's actually both answer is acceptable, but we have to individualize patient. So we have young patient with granulomatous meningitis. So we try to avoid medication that will affect the fertility. This is the one point. The other point, there is a new trial, RAVE trial. It's actually showing that rituximab is non-inferior to cyclophosphamide in the treatment of granulomatous meningitis. Besides, as we said, that we are trying to avoid the side effect of cyclophosphamide. However, if we give rituximab and then the patient still not respond to treatment, we can go for cyclophosphamide. Okay, so the right answer in this question is D, rituximab. Okay. And this is the latest ACR guideline, as we say here. In the active severe, we either go for rituximab or cyclo, but rituximab is preferred over cyclo, with the steroid, of course. And then we go for maintenance. Usually, the duration of a treatment is individualized based on the patient. Yeah, next question.
So a 48-year-old woman with history of asthma and allergic rhinitis present with left foot and right wrist numbness and weakness, which began 2 weeks ago. For the past 5 years, she has intermittent dizzy ankle and wheezing, which improved with bronchodilator, and she is currently controlled with inhaled corticosteroid. She had one episode of dizziness and with an elevated heart rate 1 week ago, but has no other associated symptoms. On physical examination, vital signs are normal, and the examination of the heart and lung is unremarkable. Notable findings include increased sensation to work in the left foot and right hand, and weakness in the left foot dorsiflexion. Results of the laboratory studies are shown in the table. A biopsy of the left shoulder nerve demonstrates eosinophilic infiltration in the wall of the small blood vessel.
So yeah, look at the table. We have NK negative, C-reactive protein high, creatinine is 1, ESR is high. So what do you think, doctor? What's your diagnosis?
Eosinophilia
Uh,
should be stopped.
yeah. So which of the following disease manifestation is most likely to increase the risk of mortality? So your diagnosis is eosinophilic granulomatous meningitis. So what's your answer? So you notice that there is NK negative in this patient. What do you think? Actually, it's not uncommon to find NK negative in eosinophilic granulomatous meningitis, and actually it carry a worse prognosis in regard of cardiac involvement. Beside high eosinophilic count, NK negative is carrying high risk for cardiac involvement. Unlike if the patient is eosinophilic granulomatous meningitis with NK positive, he will likely have renal involvement. Okay, so the answer of this question is myocarditis. Okay. As you said, this is eosinophilic granulomatous meningitis. Okay. So here, this table will help you to differentiate between granulomatous meningitis and eosinophilic. As we said, they share the ear and nose and throat involvement, upper respiratory involvement. They share it. But eosinophilic, they have more frequent atopy and bronchial asthma and allergy. They have eosinophilia, and of course, the histology will be eosinophilic necrotizing granuloma. The worst prognosis is, or the highest mortality with cardiac involvement in GBA, while it's pulmonary renal and granulomatous meningitis. And as we see here, BNK is 50 to 65% positive. In GBA, most of the patients are CNK positive. Yeah, we have two questions more. Yalla.
A 54-year-old man is admitted with sudden onset chronic dyspnea and approximately 1 cup of pneumonia. Starting phase 3 significant or positive test for TBD, one episode of uveitis, recurrent folliculitis, recurrent canker sores, for which he had negative workup for sexually transmitted disease. His review of systems is negative for fever, chills, weight loss, chest pain, and active genitourinary and GI complaints. The patient is stable with a blood pressure 95 Page 105, and man respiratory distress with an oxygen saturation 88, normal. In examination, significant was scattered postular follicular lesions. There is no evidence of sinus tenderness or southern nose deformity. There are no oral or genital ulcers. The heart and lung exam are normal. The abdomen is benign. No peripheral synovitis is noted. Pertinent abnormal tests are listed in the table. Otherwise, the patient has a normal urinalysis without hematuria, proteinuria, or serial cat. The anti-neutrophil cytoplasmic antibody panel, including anti-coagulin 3 and anti-myeloproliferative, and the test for anti-nuclear and anti-glomerular versus membrane are negative. X-ray.
So what you see in the X-ray?
Bilateral hilar.
Yeah, bilateral hilar obesities. So just look at the lab. We have high C-reactive protein. We have high ESR, a little bit leukocytosis, anemia, and creatine is 1.3. So which of the following diagnostic modality is the most appropriate? What's your diagnosis, first of all? So this is 34-year-old. It's a difficult question, by the way. Okay, because of the bilateral heart. Okay. It's actually a difficult question. So this patient have sudden onset of dyspnea and sarcoidosis. You think you find hemoptysis? So think of something else. I will give you some clue in the question. There is hemoptysis, bilateral hilar obesities. There is uveitis, skin involvement, folliculitis, constitutional symptoms. There is no fever. So he have uveitis, skin involvement, hemoptysis, lung involvement. يعني هو شوية little bit low but not too much. الاميونولوجي marker all negative. أيوة دكتورة. Yeah, exactly. So actually this patient is Bahjat. Yeah, so he is Bahjat. What do you do? I'm Bahjat. There is no immunology marker that you will follow to diagnose, so you will depend on the clinical evaluation. Usually, as Dr. Huda said, we have recurrent oral ulcer and we have genital ulcer, but it's not always there. It's sometimes it's difficult to diagnose. So you choose A. Excellent. So it's the right answer actually. The gold standard is conventional pulmonary angiogram, but CTA is the best to diagnose pulmonary aneurysm in Bahjat because it can show all the blood vessels. So as we see here, CTA is actually also non-invasive in comparison to angiogram. Rapid and can delineate vascular thrombi, blood vessel wall, perivascular tissue, lung parenchyma, pleural and mediastinal structure. Unlike the MRI, it's like the sensitivity to detect medium and small vessel vascular pathology. So Bahjat vasculitis is involve all type of vessel, large, medium, and small. Unlike the other vasculitis, we group it into large vessel vasculitis, medium vessel vasculitis, and small vessel vasculitis. Okay. So we have two diagnostic criteria for Bahjat. We have the revised international criteria, and as you can see here, recurrent oral ulcer. It should be recurrent more than or equal to 3 times per year. Recurrent genital ulcer, and everyone have certain point on it. Skin lesion, vascular region, and positive pathology test. And we have the international study group criteria, which have the recurrent oral ulcer as a start. You have to have recurrent oral ulcer, and then you have to have at least 2 more from the other manifestation. So in vasculitis general point, there is no single typical presentation of vasculitis. Vasculitis classified by the size as we said, large, medium, and small. We try every time we suspect vasculitis to take a biopsy. Biopsy is always our target. Sometimes we can do angiography for the diagnosis. Here are some helpful clues in the exam. It can help you today to choose the right answer. So if you find jaw claudication and visual loss, palpable, thickened, tender temporal artery, as we see in the first question, it's GCA. Absent radial pulse, difficulty obtaining blood pressure in young female, usually it's Takayasu. Sinus involvement or upper respiratory tract involvement, otitis media, scleritis, it's either GBA or eosinophilic granulomatous meningitis. If you find hypertension and renal vascular involvement, it's polyarteritis nodosa or Takayasu. Asthma is GBA. Testicular tenderness is polyarteritis nodosa. Pulmonary renal can happen in either GBA, microscopic SLE, or good posture. Palpable purpura is actually can come with all, especially small vessel vasculitis. So who can tell me what is this? This is actually a skin manifestation of vasculitis. What about A? What do you think is A? What is this? Palpable purpura. What about B? Lividio reticularis. C? Digital infarction. D is punch out ulcer. Okay. So all of these are actually skin manifestation of vasculitis. Last question. نبي الفيميل بس آخر سؤال. One of the female. ارفع صوتك. صوت. Which affects his work through a closer questioning if there's a long history of acute joint pain over the last 8 years. He described also the joint pain which we find can only be controlled with a high dose of Almubarek. So he described a widespread rash, sort of episode as the joint swelling is. Examination revealed benign swelling over both wrists and front is range of motion, very intimate. He has a range reported both first from the general direction which is shown. Ankylosing of the carpal bone crest and advanced secondary degeneration. Okay. So what is the most likely underlying cause of his symptoms? Okay, let's go back, analyze the question. So we have 27-year-old man. He have bilateral wrist pain. He have also it described episode of joint swelling, so it's arthritis or arthralgia and arthritis. It can be controlled with NSAID. He have episode with rash, widespread rash, and sore throat. So we have arthritis, rash, sore throat. In examination, we have in the radiograph we have ankylosis. So what do you think? It's not a straight question, but maybe if you analyze, we can answer the question. What's your thought, Doctora? Rash, arthritis, leukocytosis, sore throat. Yeah, it's true. It's adult onset still disease. What's the criteria to diagnose adult onset? Ahmed. What's the name of the criteria, you remember? Anybody? Yamaguchi criteria. Yamaguchi actually have major and minor points. The major points involve leukocytosis, rash, arthritis, fever. The point that you have to focus on combination of rash, joint pain, sore throat, ankylosis. Ankylosis is actually one of the characteristic also of adult still onset disease. He is managed with the NSAID, as I would say. There is no specific test. Usually they have high ferritin. We have to worry about mass because it's life-threatening complication of adult onset still disease. Who knows the quotidian fever? What is the quotidian fever? Because it's characteristic of still disease. Raise your voice. Okay. Any other thought? It's actually the type of fever is reaching more than 39, usually in the afternoon or the early evening. And then during that time, the patient will have the rash, they will have the symptoms. After that, he will go back to normal. Sometimes some patients, around 20% of adults still onset disease, they have double quotidian fever. So they will have it twice a day, like in the morning and in the evening. Usually the treatment is depending on the severity of the disease. In mild, they will respond to NSAID. Moderate, they will give him steroid or Damar. Okay. Anybody have any idea about the biologic that we are usually using initially and still? Usually we are going toward interleukin 1 or interleukin 6. Anakinra or... Thank you.